Next speaker is Dr. Hemalini Samant, who's going to talk on ischemic optic neuropathies, what management options we have, and how do we prevent the fellow eye damage. She is a senior consultant at Vision with Innovation Eye Hospital, Laser Center, Mumbai, another highly capable ophthalmologist to reckon. On to you, Dr. Hemalini. You're muted, I think. You could unmute yourself.
Okay. Am I audible now?
Yeah.
Okay. So, to introduce the topic, the bitter truth is that very little is known about the non-arthritic ischemic AION, its natural history, and the pathogenesis. And unfortunately, there is no effective, consistent gold standard treatment. But the good news is that 40% of the patients experience spontaneous improvement in visual acuity, but alas, 15% have a risk of developing a similar event in the opposite eye over 5 years. So what management options do we have? The mainstay of management remains reduction of the risk factors. Some of the therapies that have been tried in the past are hyperbaric oxygen, erythropoietin, optic nerve sheath fenestration, but all of which have failed. The role of aspirin remains controversial. And when the anti-VEGFs were introduced, all of us got quite excited using them intravitreally, till there were reports that the intravitreal injection itself gave rise to AION. The role of intravitreal injection of triamcinolone acetonide is as controversial as is the role of steroids, oral steroids. So, like I said, reduction of the risk factor remains the mainstay of the treatment. So what do you tell a patient who comes with NAION? Stop smoking, control hypertension, avoid antihypertensives at night, regular exercise, lifestyle changes, healthy diet, avoid alcohol binges, discontinue use of any other antihypertensives like minoxidil or Viagra, and sleep apnea, which is often underdiagnosed, should be thoroughly investigated. And if you do find sleep apnea, then treat it. Coming to oral corticosteroids. So the role of corticosteroids is popular, but yet controversial. Do they really help? So we all know that the rationale of using oral corticosteroids in this disease is to reduce the tight compartment syndrome and thereby improving the function of the surviving hypoxic axons. So we did a literature study and I came across Dr. Rohit Saxena's paper, Steroids versus No Steroids in Non-Arthritic AIONs, published in Ophthalmology 2018, where he conducted a small randomized control trial with 38 non-diabetic patients. And they found that steroids helped to expedite and enhance the structural and functional recovery in NEIONs, but their use did not result in a better final visual outcome. So if you actually review literature, you will come across numerous papers, some proposing the use of steroids and some differing. Some experts have mixed opinions where they normally steer away their patients from the use of steroids, except in some severe cases of vision loss or one-eyed patients. But it's frustrating to tell a patient with NEION that nothing is possible. And the litmus test, in my opinion, is what would you do if it were your eye? So I did this little fun thing where I called some of my colleagues to know what their preferred practice pattern is. So Dr. Rohit Saxena reluctantly gives steroids in early presentation in non-diabetics with significant edema. Dr. Ambika chooses to avoid steroids in classic NEIONs and defers steroids in patients with poor controlled risk factors, even if the window period of presentation has been less than 2 weeks. Dr. Rashmin does give steroids if the patient has come early with severe vision loss in joint consultation with a good physician. And Dr. Satya likes to reserve the oral steroid option 1 milligram per kg body weight for non-diabetics, tapering over 2 to 3 weeks. In diabetics, he's reluctant to prescribe steroids and simply prescribes Neurobion. So my protocol based on the general consensus is I offer the steroids to one-eyed or monocular patients, and also to that one uncommon patient who presents with simultaneous or sequential vision loss, but proven NEION, patients with progressive vision loss within 2 weeks of onset and who don't have steroid-related side effects, I do offer them steroids in a tapering dose, of course, in a joint consultation with the physician. But the most important take-home message is be cautious, be conservative for the use of steroids in diabetics, and in general, be conservative in using the steroids in any patient with NEION. There is definitely no role of IV steroids. So how do we prevent damage to the other eye? There is no proven prophylactic to prevent the second eye involvement. Simply reduce the risk factors that you have identified, and therefore a careful history taking is very important. Identify the disc at risk and discuss the risk factors, counsel them regarding if any. Role of aspirin, although controversial, I still do offer it to almost all my patients with NEION. Coming to Arthritic Aion, GCA is a great masquerader and early intervention is must. Most importantly, in any AION patient above the age of 55 years, do the ESR and CRP and rule out GCA because it's a true ophthalmic emergency leading to bilateral blindness. Coming to the management, the mainstay of treatment in GCA is high dose of oral steroid or IV steroids. I reserve the IV steroid option if there's complete loss of vision or if there's early sign of involvement of the other eye, such as an early dyspedema, or the patient complains of amaurosis fugax. The goal of the steroid treatment is to preserve the vision, to prevent further visual loss, to prevent the fellow eye involvement, and to hope for visual recovery in the affected eye. Almost in all cases, temporal artery biopsy should be done, but one doesn't really need to wait for the result in cases where the CRP and the ESR are high. So there is no controversy in the treatment of GCA because the steroids are the mainstay. And the steroids are to be tapered based on weekly ESR and CRP values. Premature tapering can flare up the disease. There is no fixed formula for predicting what the maintenance dose is. But most important, watch out for the side effects of long-term steroid use. And a take-home message is that it's important to identify and treat GCA patients early. Thank you.
Thank you very much.